Welcome to AETCM, the emergency medicine channel. Today let us discuss about shock management. Now shock is a condition where the cellular and tissue hypoxemia is caused due to reduced oxygen delivery or increased oxygen consumption. So there are different types of shock: distributive shock, cardiogenic shock, hypovolemic shock. But remember, all these type of shocks can be coexist. In the same patient you can have hypovolemic, like for example sepsis, you have hypovolemic shock, distributive shock, and if the patient develops cardiac failure, you can have cardiac failure also. Now obstructive shock, it is mainly due to a block in the circulation, like pulmonary embolism. That is the most common cause, most important cause for obstructive shock. Then tension pneumothorax. I am not going to the details of all these things because we are going to manage the shock. Now distributive shock, the most important condition is neurogenic shock, like shock due to spinal cord injury. Even the brain injury, you can get it. Spinal cord injury is the most important cause for distributive shock. Endocrine causes like adrenal failure, there also you can get distributive shock. Abdominal compartment syndrome, anaphylactic shock, all these conditions you can get distributive shock. We are not going to the physiological aspect of shock, we are going to manage the shock. Now whenever patient have septic shock, this septic shock, it is defined as persisting hypotension. Because of sepsis, vasodilatation occurs, vascular leak occurs, and patient can have persistent hypotension, and to maintain the mean arterial pressure more than 65 millimeter of mercury, and serum lactate will be more than 2 millimoles per liter. So to maintain the mean arterial pressure, we may have to give sometimes vasopressors. In septic shock, vascular leak is a major problem. So you can see in the blood vessels there will be leak, and because of the leak, patient can have reduced volume in the intravascular compartment, patient can have shock. This leak causes protein and fluid loss. Protein loss is very important because protein is required for the oncotic pressure in the blood vessel. So when the patient loses large amount of volume and protein from the blood vessels, patient can have shock. That is a major cause for septic shock. Hypovolemic shock occurs in patients with like severe diarrhea, vomiting, heat stroke, hemorrhagic shock, blood loss, renal conditions like excessive drug induced osmotic diuresis, salt wasting nephropathy. Third space losses occurs in the postoperative trauma or intestinal obstruction, crush injuries, pancreatitis, cirrhosis, all these conditions you can get hypovolemic shock. Now cardiogenic shock, whenever patient develops cardiac failure, especially left ventricular failure, maybe due to myocardial infarction, ischemic heart disease or valvular heart disease, patient can have cardiac failure and cardiogenic shock. Now we will see what happens in shock. Whenever the circulation is compromised, you can see inadequate perfusion, may lead to cell hypoxemia, then energy deficit that leads to anaerobic metabolism, lactate production, lactic acid accumulation in the body, pH will be reduced, that leads to metabolic acidosis, that itself can produce vasoconstriction, precapillary sphincter failure, peripheral pooling of the blood, all these things can be a complication. Then cell membrane dysfunction and failure sodium pump, intracellular lysosome release, and that may lead to efflux of potassium and influx of sodium and water, toxic substances enter the circulation, capillary endothelium damage and leak, that will lead to, finally it will lead to the excretion of fluid from the intravascular compartment to the extravascular compartment, and that may lead shock. So patient with shock can have lactic acidosis or other types of metabolic acidosis, and they also can have capillary endothelial damage. These are the common problems occur in the patients with shock. Now, what are the clinical findings of shock? That is very important. So, most of the patients with shock, they have hypotension. Systolic BP will be less than 100 millimeter of mercury. Most of them will have tachycardia. Heart rate will be more than 100 beats per minute. Cold, clammy skin. Tachypnea, the breathing rate may be more than 20. Rapid shallow breathing can occur. Drowsiness, confusion, irritability. It can be due to toxic encephalopathy or it can be due to hypoxemia. Oliguria, urine output will be very low. Reduced elevated JVP and central venous pressure. Multi-organ dysfunction syndrome including ARDS, lung failure, renal failure, liver failure, encephalopathy. And poor circulation to the brain can lead to low GCS and hypothermia. Now, these are the different types of shock. I am not going to the details. We have already explained what happens in each type of shock. You can see here, this picture will clearly tell you what happened to the each type of shock. Just for an example, we will take cardiogenic shock. Respiratory rate increases. Every type of shock it is going to increase except in anaphylactic shock. Now, we see the heart rate. Heart rate increases in all the types of shock except in neurogenic shock. Okay. So, now you see the BP decreases in all the shocks because hypotension is a major problem in all the shocks and it will be decreased. Okay. So, these are the common points and you can see the details afterwards. Now, shock index is one index defined as heart rate divided by systolic blood pressure. It has been suggested like a marker that can be used to predict the severity of hypovolemic shock. If shock index is more than 1, it can predict the risk of mortality and other markers of morbidity. No shock, the shock index will be less than 0.6. Mild shock more than 0.6 to 1. Moderate shock 1 to 1.4, severe shock 1.4 and above. Relationship of SI shock index, mortality and need of transfusion. Okay. So, all these things can be predicted by the shock index. Severe shock may require blood transfusion also. Now, hemorrhagic shock can be classified into 4 major groups depending on the percentage of blood loss. You can see here 15%, 15 to 30%, 30 to 40%, more than 40%. So, depending on the change in the blood loss, in the blood volume in the patient's body, there will be certain findings. You can see here the lot of peripheral finding and cardiac finding will be there. Depending on that, you can select either observe the patient or IV fluid therapy with blood transfusion alone. So, if the hemoglobin percent is less than 7, definitely you need to transfuse in trauma patients. Now, lab investigation, normally in shock we do certain tests like we see whether the patient is having anemia or any infection. So, complete blood count, blood sugars, ABG values, peripheral smear is important in like whenever the counts are very high. High hematocrit may indicates acute volume loss. It indicates hemoconcentration. Liver function test, kidney function test, PT-NR, APTT and serum fibrinogen for so these 3 things are very important in diagnosing whether the hematological coagulation function is normal or not. So, if PT-NR is elevated, sometimes APTT also can be elevated and that will lead to low fibrinogen levels. So, that we have to pick up. Electrolytes, most of the electrolytes can be abnormal in shock, including sometimes if patient is having hypervolemia, he can have low sodium, potassium can be reduced. And see this, I forgot to tell, PT-NR elevation, APTT elevation and low fibrinogen can maybe an indicator of DIC, disseminated intravascular coagulation. Then D-dimer is not a very good investigation, but that can be tested, something like fibrinogen. So, that can be done in intravascular coagulation. Blood, urine and sputum cultures to be done to rule out infections. ABG, mainly we get acidosis, especially metabolic acidosis. It can be even lactic acidosis. Now, this is a very useful test in clinical medicine. Capillary refill time. You can press the finger tip for some time and release it. Immediately you can see that the redness come back. The paleness, initial paleness will be replaced by redness immediately. So, we have to check that. If the capillary refill time is less than 2 seconds, it is normal. Now, passive leg raising test is another important test. You can know whether the patient can accept fluid. So, what you have to do is the patient will be in this position, then immediately change the patient to reverse Trendelenburg position. So, if the BP increases, then you know that patient can take more fluids. You can give IV fluids without any issue. The patient can accept more fluid. Now, IVC compressibility is a very important test for in emergency room to know whether the patient is having volume loss or volume expansion. You can see the IVC. You can see the IVC whether it is compressed or full. If it is compressed like this, we can give more fluid. Collapse is IVC collapse. If it is full like this, it may be dangerous to give fluids to that patient. Now, serum lactate, we already explained that this is a metabolic acidosis due to anaerobic metabolism. This anaerobic metabolism will be absent because of the hypoperfusion of tissues, especially internal organs. The lactate levels in anaerobic metabolism will be very high, and if the patient is having lactic acidosis, think that there is anaerobic metabolism because of hypoperfusion of tissues. When you reperfuse the tissues, slowly the lactate will be cleared. This is called as lactate clearance. We will see that afterwards. Other investigation, like you can ask for chest X-ray, ECG, echo to know the status of heart, cardiac ejection fraction. You can see the chest X-ray for bilateral pulmonary edema or any other infections. You can ask BNP to rule out cardiac failure. Then you can ask troponin I, troponin T to see whether any cardiac problem. So, BNP is a very important test. Brain natriuretic peptide is a very important test which will elevated BNP indicates cardiogenic shock. So, this is a very important step we have to do, and point of care ultrasound focus should be done in all patients with shock. You can see various protocols to identify what may be the lesion, especially in trauma patients and all. We can know whether intra-abdominal bleed is already there, and we already explained IVC collapsibility. All these things, ultrasound will be a very good tool in emergency room. So, point of care ultrasound evaluation should be done in all patients. How to manage a shock, that is very important. Before starting management, you have to always remember to put a large gauge IV cannulation in all patients with shock, preferably 2 cannulas to be placed. Okay. Then how do you manage these patients with hypotension, shock? Best is giving crystalloids. You can give normal saline, you can give ringer lactate, you can give plasma light, whatever you want you can give. 30 ml per kg should be given, and the CVP should be maintained somewhere around 8 to 12 H2O centimeter of water. Now, can we give so these are called as crystalloids, normal saline, ringer lactate, plasmolite, they are all called as crystalloids. Can we give albumin? Albumin is always better than crystalloids. It can maintain the intravascular compartment better than crystalloids, but the only problem is the cost may be at least the normal saline may cost around 75 rupees per bottle, but 100 ml will cost around 5,000 rupees for albumin. So, it is not feasible to give albumin in all patients with shock. Now, lactate clearance is very important when we have a patient with compromisation for internal circulation. When you give more fluids, noradrenaline, the circulation improves, and you can see whether the lactate is cleared or not. If the lactate clearance is more than 10%, you should understand that patient is having good clearance. At least 10% should be there. If it is there, you can calculate the lactate clearance by initial lactate by lactate after 2 hours by initial lactate into 100. That gives the value of lactate clearance, and if it is more than 10%, then it's a good clearance. Patient is improving in at least internal organ circulation. Then if the patient is not improving with your fluid resuscitation 30 ml per kg we have learned, then you have to go for vasopressors like noradrenaline. Noradrenaline can be started in 0.05 to 5 microgram per kg per minute infusion. Then you can keep the mean arterial pressure and target to 65 or more. So that should be targeted. You can also try for dopamine or dobutamine in patients with cardiac failure, especially dobutamine can be tried if the systolic BP, if you keep above 100, you can start dobutamine. Dopamine also can be tried if the patient is having bradycardia. Otherwise, there are better drugs you can go for phenylephrine or other drugs. So that can be tried. This is a chart given for that. Now, anaphylactic shock, we all learn anaphylactic shock should be treated with adrenaline. The dose is given clearly in the chart, so you can learn that. So, adrenaline is the drug of choice in anaphylactic shock. Now, pregnancy with shock, the management is slightly different. You have to keep the patient slightly on left lateral position. You can see here IVC is compressed by the uterus. If you turn to the right side, left side, the IVC will be IVC will be escaped from the compression. So, any patient, a pregnant patient coming to emergency room with hypotension, always keep the patient on left lateral position so that the IVC will be spared. The compression to IVC will be spared. So, that is very important in pregnancy. You have to treat like that. Other drugs like you can give hydrocortisone in septic shock as a third line of drug. You can give hydrocortisone 50 milligram every 6 hourly. You can try if a patient is not improving, or if you are using dexamethasone instead of hydrocortisone, you can even go for fludrocortisone. That also improves the BP. Now, what are the parameters which gives an idea about good perfusion? That is superior vena cava oxyhemoglobin saturation, that should be more than 70%. Then other things like CVP should be 8 to 12 millimeter of water, mean arterial pressure more than 65 millimeter of mercury, urine output more than 0.5 ml per kg per hour, and lactate clearance is more than 10%. We already discussed. pH normalization is very important, and consciousness, GCS should improve. So, these are the parameters which will tell you whether the patient is improved or not. So, we have discussed about shock today. So, short class on shock, different types of shock we will teach some other occasion. Thank you.